Let's talk about respiratory distress syndrome. What does it look like? Patient's hypoxic. Patient's obviously having difficulty breathing. Now, patient could be an adult, patient could be a child. They're going to have one thing in common though, and that's very widespread collapsing of the lungs. They're going to have a lot of fluid in their lungs causing the collapse, and this fluid's going to accumulate inside alveoli, and the fluid is going to show up as this patchy, opaque infiltrate that's got this characteristic ground glass appearance. And the fluid is going to be there because of pulmonary hypertension. And pulmonary hypertension is going to be there because there's a VQ mismatch. And the VQ mismatch is going to be there because there's lung collapse. And the lung collapse is going to occur secondary to a surfactant deficiency. Now, in the newborn, this is because they haven't started making surfactant yet. But in the adult, this is going to be acquired, and it's going to be kind of imposed on pneumocytes due to inflammation secondary to a more widespread non-cardiogenic pathogenesis. So before we really dive into this, that's a big point. For an episode of respiratory distress to qualify under this diagnosis, it's got to be non-cardiogenic in origin, because we know that left heart failure can volume overload the lungs and give you dyspnea and lead to respiratory failure, basically. But that goes under the umbrella of heart disease, technically. And for it to be respiratory distress syndrome, it's got to only involve the lungs. So, surfactant. Surfactant holds your alveoli open. Your alveoli are spheres. They're globular in shape. And surfactant coats the inside of these spheres and it lowers their surface tension. Now, you get hyaline membrane disease, which is another way of saying RDS of the neonate, whenever that baby is not making or producing surfactant sufficiently. So it's associated with prematurity because your lungs are one of the very last organs to develop fully. And if you're born late in term but still premature, there's a good chance that you might not be making surfactant. And the cutoff for that is around the 36-week mark. Now, premature birth is sometimes necessary, for the health of the baby or the mother. It's not always a totally spontaneous thing. Sometimes it's planned. So especially if you're working OBGYN, you have to be monitoring baby's surfactant leading up to the projected birth date, because if baby is born with a very low surfactant content, it will not be long before the baby is in respiratory distress, developing hyaline membrane disease. And there is a good way we can treat this, and that's by administering glucocorticoids to the mom before she delivers. We'll get there. Let's talk about surfactant. What does it do? Well, surfactant is created by type 2 pneumocytes. Please recall that most pneumocytes are your type 1 pneumocytes, and those are going to be your flat pneumocytes. And when we're thinking about gas exchange across a thin epithelium, well, that thin epithelium belongs to type 1 pneumocytes. So why do you have a second class of pneumocytes? Well, primarily to excrete surfactant onto the surface, the internal surface of those globes of alveoli. And then type 2 pneumocytes are also respiratory stem cells, which do have some sort of divisive capacity should there be an injury to alveoli. Type 2 pneumocytes will step in and differentiate into type 1 pneumocytes to replace some dead lung tissue. But today we're focusing largely on their role as the prime producers of surfactant. Surfactant is comprised of lipids. Specifically phospholipids, which are going to be amphipathic lipids. They're going to be polar on one end, nonpolar on another, and they're going to interact with various molecules that float down into the alveoli. And as a quick side note, because surfactant is a phospholipid, and then because you've got to diffuse across a couple of membranes to get into the blood, that's why the lipid solubility of a gas, and I'm thinking anesthetics here, really matters. For it to be clinically relevant, it has to be able to cross lipid bilayers in the lungs. So pneumocytes produce surfactant, and before they excrete surfactant, they kind of excrete packages of surfactant, and those packages are called lamellar bodies, and I have a quick picture to show you. This is what a lamellar body looks like. Lamella meaning like ring, kind of thinking like rings on a tree here, or lamellar meaning disc-like. So here's what they look like from the side. Here's what they look like axially. You can tell it kind of looks like a myelin sheath. And these are electron micrographs, okay? And that means that we're looking really, really zoomed in inside one cell. And just to satiate your curiosity, all these tiny little black dots that kind of look like granules, they've got a really grainy appearance. All those are ribosomes and lysosomes. So that's about the size of one ribosome for comparison. And here's another look. These lamellar bodies contain surfactant, which you might see referred to as phosphatidylcholine or phosphatidyl blank, just meaning that there's a phosphate group stuck onto a molecule of choline and then pasted onto a fatty acid. And you can also see this called lecithin. So any of these three terms can be used interchangeably in a question stem to refer to surfactant. And again, these are lamellar bodies inside a cell. And these dark disc-like structures are where surfactant is stored. So you store surfactant and then push it on out to the surface of an alveolus. And when you do this, you decrease the surface tension spread across the area of the inside of that globe of that alveolus, right? So surface tension is, don't overthink that, right? It is what it sounds like. It is the tension or the force, the pull force, because a tension is it's like a shear force almost. It's a pulling force spread across a surface. And so it's a force over an area. And so surfactant decreases surface tension. So that's a good thing in the lungs, because your lungs are always filling up and collapsing and filling up and collapsing. And also, there's always a pressure inside every alveolus of your lung, right? There's always a pressure inside it. And every alveolus has what's called a collapsing pressure, and that's going to be the threshold pressure at which, if you go under that pressure, the alveolus just falls in on itself and crumples up. So that would be bad, because it would be difficult to inflate that alveolus again when it's crumpled, because it would be a high pressure zone then. So you want alveoli to be able to expand and shrink according to inspiration or expiration, but then you also want them to remain patent. You do not want them to collapse. So the formula for the collapsing pressure of an alveolus is going to be 2 times the surface tension over the radius. So that lets you know that whenever that radius goes down, well, you need your tension to drop with that radius. Otherwise, your collapsing pressure is going to go up. And if that goes up, that means the alveolus is going to collapse at a higher pressure. So the higher that collapsing pressure is, the more prone the alveolus is to collapse. So you need to be decreasing surface tension alongside a decrease in radius or a constriction of that alveolus. So that's what surfactant is doing. This sentence sums up everything above. The dynamic properties of surfactant permit the alveolar surface tension to change with inflation and deflation, thus keeping the small alveoli from total collapse. And let me summarize this finally by saying that a phosphatidylcholine is a very mobile type of lipid, and it can absorb forces that get placed on a membrane whenever it shrinks by moving around. Because we know that, like, you can, whenever you absorb energy, you can let it off mechanically. You can let it off in heat. There's all sorts of ways to transfer energy, and the phosphatidylcholine is a particularly mobile phospholipid. Hyaline membrane disease, infantile respiratory distress syndrome. So we know that surfactant helps the lungs stay open. So what happens when you don't have enough surfactant? Well, the lungs are going to close because alveoli are going to collapse, right? And so you add those up and maybe 1 million alveoli collapse. And so that leads to a ventilation defect. And remember that ventilation is airflow, and perfusion is blood flow, and diffusion is interaction between air and blood. So if your ventilation drops, well, that's expected. Whenever your airways close, you have less ventilatory space. But if your flow remains the same, then you've got a VQ mismatch. This causes what's called a shunt. And it leads to hypoxemia, low oxygen in the blood, because the alveoli are collapsed. You're not getting ventilation. And the hypoxia in the blood is going to lead to a localized acidosis, because that's what cells do when they run out of oxygen to accept electrons to make ATPs. They go to anaerobic glycolysis, which makes lactate, which has a proton on it, which contributes to the local acidity of that environment. And the acidosis in the lungs induces pulmonary vasoconstriction. The vasoconstriction is associated with a exudate due to an increase in Starling's forces and due to damage to the endothelium. So the high hydrostatic pressure in the pulmonary capillaries combined with the inflammation accruing due to the hypoxia leads to exudate. So protein and fluid leaks through pulmonary capillaries into the alveoli. And as a result, all these globes of alveoli are going to get filled with water and fluid. And that's where you see ground glass opacities on an X-ray. Every little opaque white dot on an X-ray or CT in the lungs is going to be an alveolus that's filled with fluid. So how would we officially define respiratory distress syndrome? Well, you got to say something about a surfactant deficiency, because that's why these infants are having trouble breathing, because their airways are collapsing. And then because it is an airway collapse, you must mention atelectasis, because that's the doctor word for airway collapse. So it's a massive atelectasis due to surfactant deficiency. We also said it was mentioned or related to premature birth, right? So we also mentioned that the lungs are late to form. Well, the timeline of that means that the lungs aren't even done forming until after baby is born, because they've never had oxygen, right? And so taking that first breath is what's going to be the capstone on the formation of those lungs. But until then, well, your lungs are going to start out as tubes, and that process is called canalization, the formation of the canals or tubes of your lungs, so your conducting airways. Then around week 25 or so, baby goes into this phase called sacularization, which is where your respiratory zones start to develop. And then around week 32 or so, baby begins the process of alveolization, which is going to be the differentiation of stem cells into type 1 and type 2 pneumocytes. And until alveolization is complete, baby's got a tough time transferring gases from one side to the other. And it's related to the fact that baby's in fluid for a very long time. So baby doesn't have to transfer gases with the lungs. But when baby's born, you better believe that baby needs to transfer some gas quick. So again, the age of prematurity is highly, highly correlated with IRDS risk. If you're at 35 weeks, you're relatively in the clear, okay? So again, this is refreshing our minds on that concept that you don't have surfactant, the lungs collapse, leads to hypoxia and acidosis. Big deal there. It's going to be a local acidosis at first, but then it's just going to keep spreading throughout the body. Let's talk about gross findings quickly. The lungs are going to be fluid-filled, airless. That's a severe word. The term hepatization has been thrown around because these lungs kind of look like a liver. That's not good. The lungs are heavy and dark because they're filled with fluid, and they're even filled with blood at the worst end of that spectrum of disease, because the capillaries are going to leak and blood cells are going to extravasate through whenever the capillaries get leaky enough. Microscopically, you see a lot of pink hyalinization. And where have we seen this before? Think about this. What organ system? Kidneys and brain. What's the adult pathology that gives us hyaline arteriosclerosis? Two things. You can get it from diabetes, in which case there's a bunch of sugars smacking onto proteins, and the proteins can't go anywhere, so they just accumulate in a cell and cause some inflammation, and then the cell reacts by throwing out fibrin, collagen. So that's endothelial damage in diabetes. Number two, hypertension can give you a hyaline arteriosclerosis, most commonly in the kidneys and in the lenticulostriate arteries of the brain. So you've seen this concept before. You've seen this histopathology before. You know what it looks like. If it's hypertension, it's because the hydrostatic pressure, we're thinking Starling force, in the blood is so high that it just pushes fluid and proteins straight through a patent endothelium, and the proteins kind of shred the endothelium as it goes through. And the endothelium gets really uncomfortable and starts to lay down collagen and fibrinoid exudate. So that is the page that we're on here. Now, in infant respiratory distress syndrome, you're going to find hyaline membranes at the boundary of the air-filled bronchioles and the collapsed alveoli. So you're going to see this pathology in the respiratory zone, not the conducting zone. Remember, the lung has an anatomical hierarchy because it's nothing but branches. And you got a trachea, and then the trachea bifurcates, and then you got some primary bronchioles, or primary bronchi, and some secondary bronchi, and that's it, just all the way down. It's just a hierarchical pyramid of structure, nested structure. So what this is telling us is, hey, this is the pathology that you see, but you're only going to see it towards the base of that pyramid if you're thinking about the lung as a branched pyramid, right? So you see it at the bottom of the pyramid, and that's a useful way to look at all of these respiratory SDLs. Start by thinking, okay, where in the lungs is this pathology? Where will I see these histological changes? Because I promise you, anytime you see lung histopathology in a question stem, they gotta tell you what anatomical airway is affected by this pathology, right? So based on, well, okay, it's the bronchi, or it's the terminal bronchioles, right? That's the end of the conducting zone, or it's the alveolar ducts. Now you're in the respiratory zone. That's your differential there. That allows you to cross out 80% of the diagnoses you're going to learn for the lungs just by figuring out anatomically in the airway where are the changes occurring. And then, of course, some things are going to be diffuse, but they'll give you other signs for that. So the hyaline membranes, back to the text, represent exudate. Proteins going through a leaky endothelium. Why is it leaky? Hypoxia. Why is it hypoxic? VQ mismatch. Well, why is there's no ventilation? Airway collapse. Why is there airway collapse? No surfactant. That's it. And this hyaline change is the same exact change we're going to see in the second half of this SDL with ARDS, adult respiratory distress. We're looking at some histology, and notice that in the caption for this histology, really notice this. In the instance of both slides, the author tells you you're looking at the bronchioles. So that's what I'm talking about here, you know? You're very rarely going to have to guess. They're going to tell you you're looking at the bronchi or you're looking at the trachea, right? Infant respiratory distress, how does it present? Drastic hypoxia, sometimes drastic, might be minor, I don't know. They start off normal and then they start going downhill and then they fall off a cliff eventually if it's not controlled. The APGAR score, if you ever hear that phrase thrown around, it's got a backronym associated with it: appearance, pulse, grimace. That means if you poke baby, does it go, you know, like activity, respiration. So good baby does all 5 of those things. And just that quick scale, I think it goes like you get 0 to 3 in each category. That's going to give you it's kind of like Glasgow coma, you know, something like that. Just give you a quick overview of baby's health. Increased respiratory effort. That's the best way to say it with words, but you're not really going to, I mean, when you see it, you're going to know, oh my gosh, this kid's having a tough time breathing. Tachypnea is there, and tachypnea reflects high blood CO2 because the parts of your medulla, the dorsal respiratory group, right? Those neurons have, well, chemoreceptors connect to those neurons, and those chemoreceptors are sensitive to blood CO2. When it gets too high, you want to breathe faster to get that CO2 out your system. When it gets low, you want to breathe slower because you're in an alkalosis. So that's the tachypnea. You got CO2 sensors that go to your medulla. And you can get a hypotension. Cyanosis is common. You hear some air sounds, but they're non-specific, except for this, I mean, I would say non-specific, but really, if you're hearing any respiratory sounds in a 2-day-old baby, that's pretty specific for something, you know? Expiratory grunting, that's another way to say increased respiratory effort. So how do you work up this baby? You want ABGs, and of course, more CO2 through the bicarb equation with your carbonic anhydrase is going to give you more protons, which means a lower pH. And because your blood has to be at 760 millimeters of mercury at all times, you know, the more CO2 you add to your blood, well, the less room there is for oxygen. So that's the hypoxemia. And the VQ mismatch has something to do with that too. You can't get any new oxygen in. You've got a mixed acidosis. You're going to get a metabolic acidosis. I don't know why. I'm not going to do a half-assed job of explaining that. Oh, there it is. Duh, it's in the text. You know, it really helps if you read things sometimes. Respiratory acidosis occurs because of atelectasis. So, yeah, okay. Metabolic acidosis results from tissue lactic acidosis. There we go. What do you see on a chest x-ray or a CT? You see ground glass, grainy, bilateral diffuse opacities, opaque, meaning impermeable to light. So light hits it and bounces off. That's opaque. The more opaque something is, the less transparent it is. And the ground glass dots represent fluid in the alveoli. And then anytime you're looking at a lung, pulmonary, chest X, reticular patterns mean you see a lot of lines. And nodular patterns mean you see a lot of dots. And so nodular patterns very often indicate respiratory zone involvement, alveolar involvement, whereas reticular lines, reticular patterns mean you might have a bronchiole involvement. So the end of that conducting airway, right? Or maybe a bronchial involvement at the proximal part of that conducting airway. So we did mention quickly beforehand that you can kind of screen infants for this before they're born. So there are a lot of different ways that you can do this. Most commonly by amniocentesis if you suspect surfactant deficiency, or if the baby's scheduled for early birth. Sometimes you might have an ultrasound finding that prompts further testing. Please remember that lecithin and phosphatidylcholine mean the same thing as surfactant. They're all phospholipids. And the lecithin to sphingomyelin ratio is going to be our gold standard, quote unquote, fluid draw. If there's more lecithin to sphingomyelin inside the amniotic fluid, that's good prognosis. It means baby's making surfactant somehow. If there's not a lot of lecithin and it's, say, like, well, week 34, you know baby should be making surfactant by then, right? Phosphatidylglycerol, same thing. It's kind of a brother or a cousin of surfactant. It's a minor constituent. Surfactant to albumin ratio. Yeah, I just say no all these tests, and even worst comes to worst, we can take kind of a swab or a cell sample, and then we can look at type 2 pneumocytes in there and then count the lamellar bodies. Sounds really labor intensive, no pun intended. So again, what do we do to prevent infant respiratory distress? We give mom glucocorticoids at least 1 or 2 days and no more than a week before preterm delivery. Let's talk about the complications of infant respiratory distress, also known as hyaline membrane disease. You can get a germinal matrix hemorrhage, and that's because, like the lungs, the germinal matrix, which is part of your ventricular system, and we're talking about the brain ventricles, not the heart ventricles, the germinal matrix takes a while to form, and the germinal matrix is only present during embryonic development, but it's an important locality because it's where all these neurons are going to be popping up before they travel outwards in the brain. So it's kind of like the fertile crescent of your brain. Everything starts there. So you would get a germinal matrix hemorrhage if your capillaries were damaged. And you would get germinal matrix capillary damage if they weren't getting enough oxygen, because they're very sensitive cells, and even the slightest energy deficiency is going to ruin their day. So please be able to recognize the brain bleed associated with a germinal hemorrhage secondary to respiratory problems in the neonate. Starts between the thalamus and the caudate, adjacent to the foramina of Monroe, and we know those are the channels between lateral ventricles and the third ventricle. And the blood can go down, down, down through the foramina of Luschka, which is going to connect the third and the fourth ventricles, and it can leak out of that tiny, tight foramen and cause a subarachnoid bleed in a baby, which has a very poor holistic prognosis, even if you manage it properly. So baby can also have a patent ductus arteriosus. That's a byproduct of simple pressure gradients. Baby can get necrotizing enterocolitis if baby has infantile respiratory distress syndrome, infantile. Hypoxia leads to bowel wall necrosis, which can go downhill really, really fast because that bowel is not particularly developed in the baby, so it's not got a very good adaptive response to injury because it's never been injured, you know. It's been kind of latent throughout the entirety of embryonic development. And remember, baby's going to be sterile too. Inside the gut, you do have a radiologic finding for necrotizing enterocolitis. That's going to be gas cysts in the bowel wall. You can usually catch that with ultrasound, I'm assuming, or at least raise suspicion for it due to ultrasound. You get E. coli and Klebsiella. Those are both gram negatives. Klebsiella is an anaerobe, so it commonly affects the bowel. Klebsiella can also cause lung abscesses. E. coli just causes everything under the sun inside the abdominal cavity. Then finally, if baby's having trouble breathing, you might have to ventilate baby, and you might have to put an oxygen mask on him. And if you do, then baby's lungs might be fine. But then after you take the mask off, their lungs are going to say, oh, crap, we have to make our own energy now, you know, and we have to get our own oxygen now. And so that transition back into doing work, you know, it's like, it's kind of like, I don't know, maybe you lose your job or you take a year off college and then you go back to school or you get a really tough job. And then it's like, wow, I'm back in the world again. Like that's how these pneumocytes are feeling after they just get this free oxygen from ventilation and then it gets taken away and they're like, wow, I got to work again. So bronchopulmonary dysplasia has something to do with all of the oxygen that these cells get during the ventilation or during the oxygen therapy, because remember, oxygen can cause a lot of free radicals, can cause a lot of oxidative damage because it's got 2 electrons on it, you know, and one of those electrons can just get pulled and fly off somewhere, and that's called a radical. And so the more oxygen you have, the more likely this is going to happen, because normally your cytochrome P system is taking all these oxygen radicals and quenching them by sticking another electron on them, and other mechanisms like your glutathione peroxidase system do that. And then vitamin C and vitamin E can carry a free radical and put it onto something, can carry an electron, put it onto a free radical. But the more oxygen you have, bottom line, the more likely you are to get oxidative damage. And so that's where the dysplasia comes in. And then you take them off of the oxygen therapy. And then, well, the tissue not only has to provide the normal oxygen for your entire body, but it also has to heal itself. And so that's hard to do at the same time. So here's the histological finding for BPD. Wrapping up our discussion of hyaline membrane disease, aka infant respiratory distress syndrome, we got a couple of risk factors, namely C-section, prematurity. Prematurity is obviously the #1 risk factor, but C-section, big one, and maternal diabetes is a big one too. And the thinking behind C-section is that the stress of birth and of labor and of passing through the vaginal orifice is going to cause baby's lungs to undergo a lot of stress. I said the same thing twice there. So when baby's lungs undergo a lot of stress, they upregulate the production of certain genes because that's what stress does. You know, it kind of unlocks parts of your DNA that are only needed when you're stressed. And so if baby is never stressed, then baby is never unlocking the ability to make and release surfactant. So baby needs stress. Second thing tacked onto that is that baby goes through the vagina and baby's lungs just get squeezed. And so all the fluid in those lungs get pushed out of them mechanically, forcefully. So that doesn't happen in the case of a C-section. And okay, well, take your first breath, kid. You got this fluid all up inside your lungs, you know, like that's not easy. That's not easy at all. So you combine that with the lack of surfactant secretion because baby just got pulled out of a cut open stomach, you know, and he doesn't have to make any epinephrine or prostaglandins. And yeah, it's tough to make surfactant. Finally, maternal diabetes is a big risk factor because insulin inhibits surfactant synthesis. And these babies are typically born pretty large for their age, aka macrosomic. Macro meaning large, soma meaning body. And these babies of diabetic mothers are going to be 12, 13, 14 pounds because mommy's got a lot of insulin. And insulin is going to rub off on the baby too. And so the baby's got a lot of insulin. And so insulin means that anytime baby gets some sugar from mom, that sugar's going straight into baby's muscles and adipocytes. And so baby comes out and baby's big. And then the complication of this is that, well, baby is born, you cut the cord, and then all of a sudden, baby's not getting mom's insulin anymore. Baby's got to make his own. Baby's not used to that. And so baby can go hypoglycemic very shortly after birth if mom's got gestational diabetes, which is diabetes that starts during pregnancy. It's a whole different thing if you've got type 2 diabetes and then you become pregnant. That does not count as gestational diabetes. That's you were normal and then I was pregnant and then I got diabetes. So let's talk about adult respiratory distress syndrome, aka acute respiratory distress, because it presents like very fulminantly. Same exact thing. Surfactant deficiency causes airway collapse, which is going to cause decreased ventilation per perfusion. So you got a VQ mismatch, which is going to lead to a hypoxemia, low oxygen in the blood, which is going to lead to an acidosis, which is going to cause pulmonary vasoconstriction, which is going to raise that hydrostatic pressure in the lungs, which is going to cause some endothelial damage, and some exudate is going to leak out, and you're going to see pulmonary edema inside alveolar globules, and that's going to look like ground glass opacities on X-ray. And the big difference here is that it's an acquired surfactant deficiency, not an inherited, not an inborn, latent one. No. This is surfactant deficiency secondary to pneumocyte damage, right? So maybe you'll have some trauma to the lungs, and there's going to be this big atelectasis because of that trauma. Well, that counts as acute respiratory distress syndrome. Maybe it's going to be something widespread like septic shock. Maybe it's going to be something inflammatory. Maybe it can be a, well, it's not going to be a cardiogenic shock because we said for it to be RDS, it can't be cardiogenic in origin. Bottom line is, in the adult, it's got a lot of different causes, and they all go back to this root concept of atelectasis or lung collapse. The pathological hallmark of acute respiratory distress is going to be DAD, diffuse alveolar damage. And again, diffuse means it's all over the place. It's not focal. It's not like one alveolus just decided to clock out today. No, it's like all over the place. So that's why you get this non-specific bilateral diffuse ground glass appearance. And to give it a simple definition, it's going to be a lot of pulmonary edema, because otherwise you're not going to see the ground glassness without the pulmonary edema, right? And then you're not going to be in respiratory distress unless you've got a lot of collapse and a lot of edema. So you got to have the edema there. And then it's not going to be due to a weak heart. It's going to be non-cardiogenic. Once more, diffuse alveolar damage. The alveolar damage pulls a lot of cytokine, creates a lot of cytokines, which pulls in a lot of neutrophils. And so neutrophils are just locked on and honing in on this target, this cytokine target that results from diffuse alveolar damage. So you get a lot of neutrophils going into the lungs from all angles, all lobes. And then the neutrophils have to move through endothelium to get into the lungs. And so when they do this, protein just follows them in. So you've got a leaky endothelium with lots of neutrophils and oxidative damage. And you've got an exudate, so you've got an edema, you've got too much fluid in the lungs, and that's your ground glass appearance. Hypoxemia manifests as systemic cyanosis, refractory to oxygen therapy, because it's a ventilation defect. You can give them all the oxygen in the world. It doesn't matter if they got 100% oxygen. It's not getting to the blood because of the ventilation defect, VQ mismatch. Let's talk about diffuse alveolar damage. Again, diffuse meaning all over the place here. The most common cause of DAD, diffuse alveolar damage, and therefore the most common cause of acute respiratory distress is going to be sepsis, secondary to an infection. And when you get an infection of the lungs, again, a lot of cytokines, neutrophils are walking through the blood and they see inflammation and they go into the lungs. And then when the neutrophils go into the lungs, there's endothelial damage. Those neutrophils aren't gentle. Neutrophils start working there. What is it? Myeloperoxidase, that's the enzyme. And they're just killing everything inside if there's an infection in the lungs. And so pneumocytes get destroyed too. And so alveoli collapse when there's this lung infection and neutrophil damage. And so you don't have any surfactants, so the airway just collapses. And so that's how lobar infection of the lungs can just turn into a widespread regional atelectasis. That qualifies as diffuse alveolar damage. And you've got three phases. First, you get this exudative phase, and then it starts to resolve. Remember, an exudate is not a transidate. A transidate has a totally cool endothelium with no gaps in between cells. But you start to get some inflammation, and you start to see some gaps in between endothelial cells, and protein can just slide through those gaps. And remember, an exudate has protein in it, so it doesn't pit. A transidate pits because it does not have protein. Microscopically, there is a widespread collapse of alveoli. Why are they collapsing? Because there's fluid inside them. Why is there fluid inside them? Well, because the capillaries are leaky due to inflammation. Histologic findings almost identical to infant respiratory distress, hyaline membrane disease, right? You see a lot of pink, you see a lot of fibrin, and you don't see a lot of blank space, and you should see a lot of blank space because this is the lungs. Alveoli contain fluid. Again, you trace all these respiratory distresses back to fluid in the lungs, somehow, some way. Honeycomb lung is a characteristic gross feature. And again, what is this? It's you get fluid inside a lung space and it just keeps accumulating and it pushes and expands the lung space open. And then there's some fibrosis around that expanded space, and that's your honeycomb lung. Then if the patient survives this, there's a regenerative phase and then it goes into repair. Honeycombing is indicative of repair because again, the reason why all of these individual nested out, burrowed out big globes, the reason they have structure is because there's collagen around them. And the reason there's collagen around these honeycombs is because they had time to heal. Big point. The stem cell concerned in epithelial regeneration is the type 2 alveolar pneumocyte of epithelial origin. These cells proliferate and then differentiate into type 1 pneumocytes, thereby re-epithelializing the basement membranes. That's a big deal. So if you survive your bout with acute respiratory distress syndrome, because your lung looks like this afterwards, you can get a restrictive lung disease, which is when you have a very tough time inhaling and filling up the lungs with air because it becomes non-compliant. It's like a rubber band that's too rubber bandy. Let's talk about different causes of diffuse alveolar damage. And what I want you to recall is that, I'm sorry, this is not that section. Etiology and pathogenesis. That's the section I was thinking of. We'll get there. We'll get there. So pathogenesis of diffuse alveolar damage is talking about what's going on at the cellular level. We've really hammered this home, but I want to walk through this timeline again. Number one, you get some sort of lung damage, alveolar lung damage, and most commonly this is due to infection. Number two, in response to the cytokines associated with lung damage, your capillaries leak, right? And so in an infection, that makes so much sense because there's a ton of interferon gamma flying around everywhere and TNF alpha. And both of those are going to make your capillaries just to get some immune cells into the area. And then the immune cells indeed follow. And that's step 3 here, your inflammatory cascade. And so histologically, what do you expect to see? Well, macrophages, neutrophils, lymphocytes, T's, B's, I don't know, everything under the sun, right? And so the bottom line is this is really, really not good for your lungs because even though these neutrophils are killing the bacteria with their myeloperoxidase and ROS mediated killing, which is like a targeted nuke, you know, or a lightsaber practically, it's doing the same thing to your pneumocytes because neutrophils don't have eyes. They just kill everything. So that's going on in your lungs. So the fluid that's leaking into your interstitium due to step 2 here ends up getting into your alveoli, and then that's what's going to be what causes your alveolar collapse due to increased surface tension because all the fluid in the lungs, that is surface tension. It's a force, yo. So they collapse, then VQ goes down, and then you get hypoxemic. That's step 6 here. And we refer to that as a intrapulmonary shunt, and that's a big term to understand here at the start of our endeavors into the respiratory system, because a shunt in the lungs is not quite the same thing as a shunt elsewhere. When we think a shunt elsewhere, we think, okay, well, you've got a capillary blockage, so you just grow another capillary, right? But a shunt in the lungs is an alveolar blockage. It's a ventilation defect. When we say a shunt with regards to the respiratory system, it's always a V defect, which is the opposite of a Q defect, a shunt elsewhere in the body, you know. Because elsewhere in the body, if we had a shunt, that would mean that there was a blockage or a insufficiency of some blood vessels flow. But that's not what happens in the lungs. You get a shunt in the lungs when there's a deficit of air, a ventilation defect. So let's run through this stepwise one more time. You get some sort of inflammation, your surfactant goes down, your surface tension goes straight up, and your lungs are going to close and collapse. And this means no more ventilation, leads to hypoxemia, leads to acidosis, leads to pulmonary hypertension. You get some fluid in the lungs. That's what gives you the respiratory distress. Symptoms: acute dyspnea, hypoxemia. Again, those are, you can test for causes of these things fairly quickly. Acute pancreatitis is something that's very specifically correlated with respiratory distress. I'm not too sure why. And then patients developing ARDS typically have something else going on, right? It's never just, oh, respiratory distress right out of the blue. No, no, no. And that's what we were about to talk about. The etiology and pathogenesis of diffuse alveolar damage and respiratory distress. Now, how I have this classified in my head is lung causes and extrapulmonary causes, right? So inhalation injury, that's a lung injury. Pneumonia, that's a lung injury. Oxygen toxicity, that's a lung injury. But then hypovolemic shock, that's probably not a lung injury. Fat embolism, well, yeah, that's a lung injury, but that started elsewhere. Transfusion, diffuse injury, not necessarily a lung injury, right? You got to understand that diffuse alveolar damage is diffuse because it's diffuse. Don't overthink that either. Everything on this list is diffuse because it's a non-specific, non-localized problem. It's something in the blood that's having a bad reaction against your lungs, okay? So what that thing in the blood is going to be different across all these etiologies, but they do have in common that they're going to damage the lungs everywhere in the lungs. Number one cause, again, lung infection. Mycoplasma and viral infections, most common causes of infectious ARDS, but then septic shock can give you ARDS. That's typically bacteria. So the mechanism for that, again, a lot of neutrophils reacting to the cytokines. The neutrophils kill everything, including your lung cells. It's all downhill from there. How else can you get RDS, or diffuse alveolar damage? Circulatory shock. Hypotension leads to inadequate tissue perfusion. At necropsy, autopsy, whatever, the lungs are the organs most commonly affected. In shock, alveolar walls are hypercellular due to the accumulation of neutrophils. The sequestration of neutrophils in the pulmonary microvasculature produces the engorgement of the lungs, characteristic of shock lung. So neutrophils stick onto the walls of capillaries. That's what it means when it says they aggregate into microemboli, but they cannot traverse the alveolar capillaries because your endothelium needs to express a specific cell adhesion molecule. I can't remember which one it is. I think it might be PCAM, but there's one that is specifically expressed on endothelium that lets neutrophils extravasate into tissue. So neutrophils can stick onto the wall all they want, but if they can't move through the endothelium, it don't matter if they're there or not. But if they are there and they're there, they're going to do what neutrophils always do when they're activated, and they're just going to take their lightsaber and just, get a 100 kill streak up on that endothelium. So shock means neutrophils stick to the capillaries of your lungs, but don't go into your lungs. And then the neutrophils are going to just degranulate and pop off on that endothelium. And this is going to be very, very similar to the oncopositive vasculitides. Because remember with those, what are we seeing there? Damage to a vessel wall. That's what a vasculitis is. And what was the agent of damage in that case? Well, activated neutrophils. And why were the neutrophils activated? Because antibodies were targeting these things and getting them to flip on. And so the neutrophils were stuck to the walls of blood vessels, not inside tissue. They were on the walls of blood vessels, and they were just popping off. Same exact thing in circulatory hypovolemic shock. It's just like the oncovascularities. Blood transfusion can lead to a diffuse alveolar damage, right? And typically an antibody immune system thing. So if there's antibodies in your blood that are harmful to the lungs because they encourage immune aggregation, well then that's not going to affect one region of your lungs. No, that's going to affect all of your lungs on both sides. So it makes sense why it's bilateral, diffuse, everywhere. Fat embolism. Now, you might think, well, a pulmonary embolus is a localized effect, right? But what we're really talking about with the diffuse alveolar damage is this sentence here that mentions the toxic effect of free fatty acids released by pulmonary lipase. So pulmonary lipase cuts fats and produces a lot of free fatty acids in response to that, right? And so that's really bad for your lung endothelium because they're thin and they want thin membranes. They don't want a lot of fat sticking on those membranes. And if that happens, well, then they're going to get damaged and they're going to go fibrotic. So you get a fat embolism. It's not the embolism itself that causes the diffuse damage. It's the triglycerides that get cut into free fatty acids that are toxic to pneumocytes. Cardiopulmonary bypass. We don't do this as often anymore because our surgical techniques are better. But whenever you do have a bypass, you got to run someone's blood through a machine. And when that happens, you know, there's a risk of something from the machine, even though it's as sterile as can be, just kind of sloughing off into the bloodstream. And then whatever is on that machine might cause some sort of complement activation because complement is indiscriminate and it just activates all the time against anything it sees. And to help you remember that, you have this thing called decay accelerating factor. And this is an enzyme or a protein whose job is to go around and look for complement that's stuck to your own cells and inactivate that complement. But if it's stuck on a microbe, it's not going to inactivate that complement because you need that complement. So remember, complement attacks everything and complement gets triggered by foreign materials. So the foreign materials that come from a bypass machine can put a lot of complement into circulation, and in the lungs this is particularly notable because you got a lot of surface area of blood of endothelium inside your lungs, and so that complement reactivity against endothelial cells just gets multiplied, magnified in the lungs. Let's talk about oxygen toxicity as a cause of ARDS. We know that oxygen can produce radicals because it's got a couple extra electrons on it and it interacts with a lot of different things. Under normal conditions, oxygen is reduced by cytochrome oxidase and any active radicals are limited by SOD, superoxide dismutase, catalase, and other antioxidants. However, if there's way too much oxygen at one time, so you give someone 100% and they really need 50%, then they can get some oxygen toxicity. And again, is that going to give you a focal alveolar damage? No. If you get alveolar damage as a result of oxygen toxicity, it's going to be diffuse and it's going to be everywhere, and the patient's going to have a really tough time breathing. So that's your ARDS diagnosis. Then finally, aspiration of gastric content. And I love this statistic. Let me tell you something, If you, as a patient, aspirate gastric content, your odds ratio of getting ARDS is 52-1. That means you are 52 times more likely to get acute respiratory distress syndrome if you aspirate than if you don't aspirate. So that's how strong this correlation is, So that's why that predisposition is so high that just adds to the reasons why you ought to take the utmost care as a practitioner anytime you're doing any sort of tubing procedure. You know, like you got to calm the stomach. You got to like double check if they've eaten anything. You know, you got to take all the necessary precautions to prevent aspiration, because it is like that with respiratory distress. And again, typically it won't be like as soon as they aspirate, but it can be a day, 2 days, 3 days after this event. And the aspiration can lead to an anaerobic sepsis of the lungs, right? And we know that infection can predispose to RDS. It's the most common cause of RDS. So how do we treat these patients at the end of the day? Well, when you're in respiratory distress, you got a lot of fluid in your lungs, and so your lungs are prone to collapse. And so we're going to use what's called PEEP on these patients, and that stands for positive end expiratory pressure. And so patient breathes in, patient breathes out. And at the end of their breath out, we're going to flip on a switch to make whatever they're breathing in have a positive pressure, to make it more likely to go into the lungs, because gas is diffused from high to low pressure. So we take their oxygen canister and we just turn the pressure up on it. Basically, we pressurize it to let it move into the lungs, because the lungs are higher pressure. So what the patient is breathing has to be higher pressure too for air to move in there. Otherwise, the ventilation defect just continues. All right. Man, that was a fun SDL. So the lungs are really cool so far. Hope you guys learned a lot about RDS. And let's go on to the next one.